morning. Welcome all of you for the next symposium, symposium number 3, which is on stillbirths, making every baby count. So we have 3 presentations for this symposium. The speakers will be Professor Neelam Agrawal, and then Dr. Kapila Jayaratna and Professor Atula Kaluarachi. The first, shall we start with the first presentation? Professor Neelam Agrawal is joining virtually from Chandigarh. Professor Neelam is a professor in Department of Obstetrics and Gynecology in PGIMER, Chandigarh, India. He is the coordinator and part of Perinatal audit team for stillbirth surveillance review and response under the NBBD, and was the national president of Indian Menopause Society from 2018 to 2019. Professor Agrawal is the co-author of second prize winner post-listed classifying stillbirth in a tertiary care hospital of Northern India and simplified version of Kodak in Obstetric Medicine Update 2018 at Hyderabad, awarded by Johnson Gardosi, and won the IOG Dr. Satya Paul Awards in 2019 for excellence in menopause research and services. Professor Agrawal has been a peer reviewer for many index journals like BJOG, BMC, JMH, etc., and chief auditor of the Journal of Midlife Health from 2016 to 2018, and an associate editor of BMC Women's Health 2019 to 2020, and senior member of editorial board of BMC Women's Health. Now we will listen to him, Professor Neelam Agrawal. The topic is audit and review of stillbirths. Over to you, Professor Neelam Agrawal.
Thank you, Chairpersons, and at the outset, my regrets for causing inconvenience of a few minutes loss of time. But anyways, that is the this thing with the virtual conferences. Anyways, and next, thanks to Dr. Anoma for giving me this chance to present this audit and review of stillbirths, which she has really given us a chance for the last few years to do it in practical this thing in India. So I will be covering my topic first theoretically, how to do review of stillbirths, and then I will show you my own experience, what we have done with the help of WHO CRO in India, right? Thank you. So what is an audit? Audit, according to WHO definition in MDSR guidelines and in making everybody count, is the systematic and critical analysis of quality of care in the broadest sense, which assesses the impact of procedures for diagnosis and treatment on patient outcomes. So it can be an audit for any of the conditions. So is it the same thing, review as well as audit, or it's a different thing? For example, maternal mortality audit, everybody knows about maternal mortality audit, and it's a well-established norm in the clinical practice. Maternal death review is also a term which is used for with the similar meaning as the maternal mortality audit. So that means audit and maternal audit, mortality audit, and maternal death review is the same. Similarly, stillbirth review and stillbirth audit can be used interchangeably. So this makes you doing an audit or a review makes you feel good and you feel like doing better, right? So going ahead, if we compare maternal death review and stillbirth surveillance and review, so all of us, we know that in spite of sharing the same period of highest risks by the mother and the fetus, and they are treated by the same healthcare providers, but they are treated differently. Mothers are treated differently and fetuses are treated differently under the same circumstances by the same people. So what are the primary objectives of a audit? We want to establish a framework for knowing the burden of the disease and then getting information from that framework about modifiable factors. Modifiable factors are the ones which can really reduce or prevent a certain condition. So from that knowledge, we can get in. We can do appropriate actions by making appropriate recommendations, and informed decisions can be taken. And then these decisions can be monitored and used to improve care. Secondary objective is, while that is the primary objective to get the good care, secondary objective is that you can get good data, and you can have major causes of stillbirths, and you can raise awareness amongst the different key holders, thereby bringing about an improvement. So basically the aim is to prevent preventable stillbirths. So guiding principles for any audit or review is that we should be focusing on the health systems, not the individuals, because that is the main hassle. Because if we are blaming an individual, then that person has a tendency to hide a certain facts, and we cannot get the proper information. So the death reviews or audits should, so audit is a term which is not usually liked. This means maybe something medical legal action or some punitive action. So that is why the term review is better to be used than audit. Stillbirth review than stillbirth audit. Okay, reviews should focus on the health systems and should be taken as a learning opportunity to improve quality of care. Main source of review is the information which is documented in the case file. That underlines the importance of proper documentation, right? So the review should be based on no name no game, no name no blame policy. And these reviews are incomplete without response. There is no meaning of doing reviews if you are not going to create any responses and follow those responses. So we have to suggest responses based on the review findings and then implement those responses. So to start with, it is better to start small, learn from your own experience, refine and adapt as you scale up. Even if there is no death, a zero reporting principle should be uh, adopted. So, how to do it in practice? How to start stillbirth review in practice? So, this should be based on making everybody count. There is a full book on making everybody count, and everybody has to set up their own system depending upon their own needs. So, system can be developed regardless of a facility. It is not that if you have a tertiary hospital, secondary hospital, or a big setup, then only you can do a review. Even your local in-house reviews are also possible. They can be made a part of the other reviews going simultaneously during that time in your facility, or maybe quality improvement process. There also you can add this review as a part of that. Then the question is, who will take the lead? So whosoever is there, the main person can take the lead. It can be a doctor, treating doctor, nursing officer, midwife, pediatrician, any administrative person or public health person. So worldwide, there have been different champions and different leaders for these reviews. For example, in Brazil, stillbirth reviews are led by the pediatricians. In Uganda, midwives and community leaders. Whereas in India, we have taken obstetrical team to lead. Whosoever leads, let him be a leader. Somebody should be a leader, right? Then that leader should identify the team members, and there should be enough capacity building of the team by training workshops, telephonic physical visits, and coordinating between the different team members. And these can be the different team members, as I have already told. And from these different team members, one person should be made a chairperson just to coordinate the whole teamwork. Somebody should be the chairperson. Then there should be, from the treating team or from the managing team, there should be the presenters who will present to the chairperson. Then from where they will present, they need to have a data manager for record keeping, and then there should be some members in the team who should review these findings, and these all should be presented to the chairperson. So chairperson should be convening the meeting at regular intervals, facilitate discussion, and basically coordinate by establishing some ground rules and codes of conduct so that there is no chaos, right? So presenter should be the one who should be presenting, who should be collecting all the information after interviewing the staff, as well as if possible with the patient, and make summary and present at the time of the meeting. So for convening the meeting, chairperson is the leader and secretary is the one who will coordinate in making the agendas and sending all the invites and everything. Data manager will periodically review data trends and input data quality and database management. So all members, their role is to participate in review of deaths in the facility and recommend and participate in implementation of the action plans, and also ensure confidentiality of the meetings and ensure linkages with if there is any other ongoing program by the government or by the hospital. And how often should the meetings be held? Meetings should be held at regular intervals depending upon the convenience of that particular facility. And some thematic cases should be reviewed because not every case need to be reviewed to reach a diagnosis, suggest a solution, and implement the changes in routine practice. So steps are, there are 6 steps in any review or mortality audit cycle, but which are well listed. These have been taken from the making everybody count. I have taken these 6 steps. These are copied from there. First is identification of the perinatal. This here we are dealing with the stillbirth. Identify stillbirth, collect information, analyze the results, recommend solutions, implement recommendations, and then you supervise, evaluate, and monitor these recommendations and refine them so that finally we can attain some improvement. So stillbirth cases, how to identify stillbirth cases? So we must look in our own facility, where are stillbirths likely to occur in my own facility. So list all those places in your facility to capture the stillbirths. Then collect necessary data which needs to be used for analysis of the stillbirth, and collect additional information which can make us richer by understanding delays or modifiable factors. Modifiable factors are the preventable conditions which could have been prevented for a better outcome. And keep some timeline, for example within a week or whatever, some timeline has to be kept to collect the information. So aim of collecting the information is to know the burden as well as quality of care and the modifiable factors, if there was any, to understand delays where it could have been prevented. So minimum data set which is needed for a stillbirth review is maternal age, place of delivery, mode of delivery, birth weight of the baby, gestational age, and outcomes. Then this information needs to be analyzed. And these are the guidelines for selecting cases to review, which can be customized according to your own needs. So at least minimal set of indicators must be used, and context specific approach. Context specific means specific to your own area, right? So, and for example, low volume sites can review all their perinatal deaths because there are hardly any deaths. There are just few deaths. High volume sites can have thematic cases chosen, and then at national or regional level, it may be efficient to select random sample of the thematic ones, random from the thematic, and review those. And cases which we select for review should be reviewed in detail by taking all the factors in consideration, like background, socio-demographic, availability and quality of antenatal and intrapartum care, and then assign the cause based on these, and definitely try to pick up modifiable factors, that is the missed opportunities. Even reviewing single death can generate useful information and can teach us some lessons which can prevent future similar happenings. And after that, recommend the solutions, and solutions should be just remember this word smart. Solutions should be specific, should be measurable, should be appropriate, relevant to that place and condition situation, and should be time bound. Right? For example, possible actions include interventions in the facility, in the community, linked health center or sector, or public sector. So, how do you make the recommendations? Identify the failures in the care provided, right? Not only to the fetuses which have died, also to the remaining ones who are living. That means the bereaved parents and the families. Focus on the modifiable factors, that is missed opportunities. Classify the failures into health system failure, health facility failure, health workers failure, but without naming a person. No blame, no shame, right? Without shaming anybody, without blaming anybody. And then bias the recommendations towards those that are health facility and health worker modifiable factors, not towards the health workers. I'm time and again emphasizing that uh, don't target a particular person, target the particular factor, modifiable factor in that person also. So start with those which do not require huge output, for example, money to implement. Identify mechanisms how to promote stakeholders and recommend only positives, not the negatives. For example, a sample recommendation made in that book is that matron in charge of the maternity should ensure that every staff member who delivers a baby not breathing, that means a stillbirth, should first resuscitate the baby according to the national guidelines, starting from this date, and then follow up after 6 weeks how much was done. So these are the smart solutions which I have told you, and should be uploaded on a portal for implementation if there is a well established portal system. For example, in Sri Lanka, I believe there is a well established online portal system, but it is not present everywhere. So if there is a solution, smart solution should be found by everyone, but if possible, upload it on the portals if there are any. So then you have done the review, you have suggested the recommendations, but till it is implemented, there is no use. So the whole purpose of this action cycle is that you implement recommendation, and who will implement, what will be implemented, and till what time. So that is why before also I said leadership is important to implement recommendations. So this is the mortality audit cycle complete. Complete mortality audit cycle is that identify, report, review, respond with an action, and then monitor that action and see the improved quality of service delivery and check the outcomes, right? So again, same thing. Start with things that are easily achievable. So now I will tell you, this is the in general how to do mortality stillbirth audit or stillbirth review. So I will tell you how we do in our setup, and this has been all done after we did 3 years of surveillance. Then we started with review, and Dr. Anoma has a very great part to play in this, in motivating us, and then she has been consistently after us to do this and that, and this has brought about a lot of improvement. So thanks, Dr. Anoma, once again, and the WHO team, the whole WHO team of Dr. Anoma, Dr. Neena Rana, Dr. Dheeraj, Dr. Rajesh Mehta, and Dheeraj. They are all helpful to us. So what we do, from our delivery book, from our septic labor room and clean labor room, we identify the cases. Stillbirth tool is there, which is filled by the doctor who conducts the delivery. And in the morning, that delivery, that stillbirth is reviewed by the unit consultant. And after that, every month, stillbirth audit team reviews it in the monthly audit. And then it is yearly reviewed. In the yearly review, we pick up some sample cases and then see. Then suggest some recommendations and see the implementation of changes. So this is the what how we do the recommendations. We select the topic, identify best practices, do the literature review, and after we present that case in monthly audit and taking a feedback, then we do make the final consensus and recommend a solution and put it into changed practice. And we select some thematic cases. For example, we take 28 weeker or 1 gram and collect information whether it was an antepartum or intrapartum or maternal. On these three factors, we collect the information: antepartum period, antenatal period, intrapartum period, and on the mother. And then, for example, in 1 month from 4,000 deliveries, we picked up 134 cases, and from there we picked up the modifiable factors, which were the missed opportunities at various levels. For example, at the patient related level, at the administration related level, and healthcare provider related level. In the patient related, they did not come for antenatal care, or they came very late and they did not have any knowledge of danger signs, and there were cultural inhibitions or communication gaps. Right? In the administrative level, there were lack of delivery facilities, there were not enough ventilators for the premature babies, and maybe there was insufficient staff which was required to take care of that patient. Right? Then personal healthcare provider related: incomplete documentation, inappropriate action, delay in referring the patient, and failure to follow best practices. These were some of the modifiable factors which we found in that monthly review. Then intrapartum modifiable factors, also patient related, in not reaching well in time, or not enough facilities, or some delay or mismanagement or inappropriate knowledge or action from the healthcare workers. So I will show you some examples from our monthly perinatal meet, December 2018, because thanks to Corona, we have not been able to do physical meets, but we have been doing virtual meets in 2019. But this is, I'm showing you a few examples how we did. 24 years old, primary gravida, 39 weeks. She was a booked patient of ours and was admitted with gastroenteritis, and she had intrapartum stillbirth. Uh, uh, and the baby weight was 2.1 kg. So it was found that fetal growth retardation restriction was missed in the antenatal period in this case. If that had been picked up, maybe she would have been induced before 38 weeks, at 38 weeks, or before 39 weeks. So this gastroenteritis, which is an incidental condition with the mother at 39 weeks, that might could have been avoided. So what was the mortality audit team recommendations? Start measuring symphysis of fundal height after 24 weeks for all mothers, so that fetal growth restriction would not be missed even by the junior doctors. Then suspected FGR cases to be shown to the senior faculty, and to follow standard growth chart, intergrowth 21 charts for following the fetal growth restriction. And in cases of fetal growth restriction, consider induction of labor at 37 to 38 weeks. And other recommendations along with this was strengthen the obstetrical triage, regular feedback for the referral to the referral centers, and learn by discussing preventable causes of stillbirths and sensitize the junior doctors, and identify best practices after reviewing the available literature and make standard protocols. Similarly, in another case, 24 years old primary who was admitted at 40 weeks with decreased fetal movements, and had a intrapartum stillbirth. Here she has had enough antenatal visits, 6 antenatal visits, hemoglobin, blood group, VDRL, everything has been done, but not the blood sugar. And this baby is 4 kg. So recommendation made was that interpretation was that this was not diabetes was not kept in mind, So recommendation was that these all pregnant women between 24 to 28 weeks should have 2 or 75 gram oral glucose tolerance test. And if some high risk factors, for example, obese patient, previous CDM, family history, macrosomia, according to ethnicity, can be even screened earlier. So uh, these are the implementation of recommendations. So there is a genuine need to sensitize each and every gynecologist as well as pediatrician. Then only actual cause can be assigned and prevention can be planned. And like maternal mortality, each stillbirth should be investigated. Let us ask ourselves only, do we react for a stillbirth the same way as we do for maternal mortality? No. All of us honestly would think that no, because we know that woman has next chance, right? That is the attitude by all of us, but which needs to be changed. Accountability of each pregnancy should be kept, whether it is ending in an abortion, stillborn, or live. And we should have a uniform system of classification for assigning a cause. And ICD-PM has been found to be a good system which keeps minimum to unexplained, right? It is our attitude which determines our direction. If we are sensitized and committed towards stillbirth prevention, we will be able to do it. So, to just summarize, we must do stillbirth review based on principles from making everybody count, and stillbirth review to assign the actual cause of death by not a blame game but accountability. And we should need to concentrate on quality of data and emphasize modifiable factors, because this only will uh, show us the missed opportunities. So, like MDSR, this stillbirth response and review should also be linked with point of care quality care. Full time staff and enough financial support is needed for all this. So, analysis of data, SBSR trainings, country specific context to be used for causes and actions to achieve single digit target in app. And this SBSR or perinatal death surveillance and review should be linked with MDSR. But SBSR has to be kept as such differently, because in places where maternal mortality has come down but still stillbirths are there, so linking with MDSR will miss those cases. So SBSR has to be given a definitively a place. Then national bodies, key stakeholders, opinion leaders must be involved to raise awareness about stillbirth, and we should bring government on board for policy interventions for stillbirth care. And thank you very much. And we are grateful to WHO CRO for financial support for starting this stillbirth surveillance and stillbirth review in our country. This is the team. Thank you so much.
Thank you very much, Professor Neelam Agrawal, for that very comprehensive talk. Next, we'll move on to next speaker. Our next speaker is Dr. Kapila Jayaratne. He is a consultant community physician, currently working as the National Program Manager for the Maternal and Child Morbidity and Mortality Surveillance at the Family Health Bureau, Ministry of Health. Dr. Kapila Jayaratne graduated from Faculty of Medicine, Colombo, and obtained Master's and Doctorate in Community Medicine from Postgraduate Institute of University of Colombo. He had his postdoctoral training at the University of Melbourne. He is the focal point for surveillance of maternal deaths, maternal near misses, infant deaths, birth defects, and injury-related child deaths. He was a past president of Perinatal Society of Sri Lanka and a former honorary secretary of the Sri Lanka Medical Association. Over to you, Dr. Kapila. He will be talking to you on stillbirth, progress, and unfinished business in Sri Lanka.
Good morning to you all. I think you all have seen this slide over and over again, but still I would like to reiterate our vision, a country in which there are no preventable deaths of mothers, fetuses, and newborns. So Dr. Agravel also mentioned, so we have done very much better in maternal mortality reduction over the years, and you see the from 1995 to 2018, we have reduced maternal deaths, and provisional figure for the year 2019 is 28 per 100,000 live births, just 92 maternal deaths. In a context of low maternal deaths and also infant deaths, you see in 2017 we had 2,867 infant deaths with an infant mortality rate of 8.8 per 1,000 live births. So our infant mortality rate also in a relatively good position, and then we have to focus on stillbirths. So we focus on stillbirths way back in 2002. I think it was one of the reasons why Perinatal Society also started same years. So you see over the years how the stillbirth rate declined in Sri Lanka. This is based on RHMIS data of Family Health Bureau. When you look at the perinatal death surveillance system, we have solid data for the year 2015. You see the number of stillbirths, 1,728. Although our perinatal death rate is good, 10.1, and stillbirth rate of 5.3 per total births, the number of stillbirths is relatively high, but compared to other countries, we are doing well. Last year, we had a review of our perinatal death surveillance and response system, and we produced a report and which shows a reduction of annual rate of reduction of stillbirth rate of 4.6%. The much focus has to be on intrapartum stillbirth rates. So you see that is another quality indicator of our perinatal care. So for the year 2017, we had 6.8% intrapartum stillbirth rate. When you look at the causes, we couldn't separate out the causes for stillbirths and early neonatal deaths, but in total, for the both perinatal deaths, both stillbirths and early neonatal deaths, congenital abnormalities are the main reason, nearly 28%. Then low birth weight and prematurity, 15%. You see the other causes which implicates for the Sri Lankan situation. So how we reduce stillbirths? So the world literature says what steps to be followed. The first thing is invisibility of stillbirths. So making the unseen seen. Then information on making stillbirth count, where, when, why. Then on the interventions, we have to focus on evidence on what works. Then at implementation level, integrated care with triple benefits and setting goals like SDGs and research priorities. So in making the unseen seen, which is counting stillbirths, so we had a legal framework way back in 1867, which defines stillbirth in a more or less scientific way. So then there is civil death registration system, and we had field routine data covering stillbirths, and we started perinatal death surveillance and response systems. So civil death registration systems, they also gave stillbirth rates, or more or less perinatal mortality rates, based on data from proclaimed areas. In 2006, Sri Lanka started perinatal death audits, mainly from the backing from College of Obstetricians and Perinatal Society of Sri Lanka and Family Health Bureau. So there was a structured system, and with time it evolved to achieve its targets with added quality dimensions. So we had a structured format for individual data collection on each and every perinatal death. Then in 2015, we launched National Fetal-Infant Mortality Surveillance System, in which perinatal deaths and also stillbirths is a major component. In 2015, we tried to streamline stillbirth registration. So the what you call Malaupanna Sahatike, or the certificate of stillbirth, so it was relatively not done, virtually zero. So with the Ministry of Health intervention, so we sent a circular to all the hospital heads that you can't dispose the dead body without registration. So in 2017, there were 81 specialized hospitals, and last year we had nearly 90% coverage in registering stillbirths with the civil death registration system. What is a stillbirth? A definition is needed, so we adopt WHO international definition, which is more than 1,000 grams or more than 28 weeks of completed gestation. So this is in line with the legal provisions which is stipulated in the particular bill which is issued in 1867. So in 2016, WHO released two guidances. One is making every baby count, and also the structured objective classification of perinatal deaths. So earlier what we used was Wigglesworth classification. Then we thought of adding this as another dimensions to for the Sri Lankan context also. With that, we introduced P1, which is individual perinatal death documentation format, and before that what we got was the monthly summary of the perinatal deaths from each health facility, but with the introduction of National Fetal-Infant Mortality Surveillance System, we collected individual data to the national level. So this covers basically all the variables. Actually, this is done with the collaboration with Sri Lanka College of Obstetricians and Gynecologists, and also Sri Lanka College of Pediatricians. So in 2017, we wanted an objective classification and to know more about these stillbirths and perinatal deaths. So we introduced pathological postmortems, and we formulated guidelines with the help of College of Pathologists and also College of Forensic Pathologists, and inputs from College of Obstetricians and College of Pediatricians. So basically what we wanted is the promotion of pathological postmortems, and the most difficult part is the consent and to give a probable cause of death. And when then comes the equipment. So from Family Health Bureau, Ministry of Health, we provided necessary equipment to nearly 60 hospitals, and also have a reporting system. In the year 2019, this paper-based system, we changed it into a web-based system, and now because of the COVID situation, there were few issues, but all in all, there are 107 specialized hospitals in the country, and out of that, nearly 87 are reporting perinatal deaths into the web-based system. We have given them all the login details, and it's a real-time data system, but there are gaps in giving this data to the system. When you look at the stillbirth prevention throughout life cycle, this is what WHO recommends, and based on that, there are several guidance stages where we can do, say, reproductive health, then pregnancy, then childbirth, and if a death occurs, what to do. So, interventions that prevent stillbirth in this continuum of care for reproductive health. So, there are several categories. I think Prof. Atula Kalwarachi will elaborate on these clinical interventions. I will show you what we did at population level and from the Ministry of Health. So, it's a life cycle approach, and basically maternal and child health care. So, you know, starting from the pre-pregnancy care, and antenatal care, intranatal care, so postnatal care. So, the cycle goes on, is implicated in stillbirth prevention. So, it's a package, integrated package, we implemented at community or clinic and institutional level. So, we start with registering eligible families for the year 2018. Our coverage is 97% out of estimated eligible families, and family planning, so you are increasing, and we achieved 68% in the year 2018 as our contraceptive prevalence rate. Then adolescent health started from the Family Health Bureau, and it includes a national strategic plan on adolescent and youth health. So, it covers basically almost all areas, and there are guidelines. Then antenatal and postnatal care, you see the impressive indices, what we are doing and what we have achieved, more than 90%, and hospital rate of 99.9% deliveries. So, antenatal clinic attendance, nearly 96% in the year 2018. And again, the WHO has put forward interventions based on evidence, but works on stillbirth prevention. They have highlighted 10 items: periconceptional folic acid, prevention of malaria, syphilis detection and treatment, management of hypertensive diseases, diabetes, management of fetal growth restriction, the identification and induction of mothers with 41 weeks of gestation, then skill care at birth and immediate care for neonates, basic emergency obstetric care, and comprehensive emergency obstetric care. So, where are we? So, in periconceptional folic acid, so our coverage is 78% in the year 2018, and prevention of malaria is, we are now malaria-free country, so we have achieved the maximum. And syphilis detection and treatment, we have eliminated this year. So, We got the elimination status in mother-to-child transmission of HIV and syphilis. Then the detection and management of hypertension and diabetes in pregnancy. So the national clinical guidelines are available. We have specialized care and multidisciplinary approach and shared care. Then the management of fetal growth restriction. So we have antenatal clinic 8 visits, more than 90% coverage, serial fundal height measurements and documentation 100%, ultrasound scanning more than 90%, availability of specialized care at delivery 94%. So we are doing well. And then comes the identification and induction of mothers with 41 weeks of gestation. So coverage of dating scan more than 90%, 92%, availability of documented ultrasound confirmed date of delivery. You know, we are doing well. Then national guidelines on post-term pregnancy, they are available, and specialist care. Then we have guidelines and facilities for induction. Although we have a high rate of induction, 35%, but so we have all the elements for the 41 weeks of gestation mothers. Then skilled care at birth and immediate care for neonates. You see the impressive rate. So 99.9% over the last 50 years, 5 decades, what we were doing. And availability of basic and comprehensive emergency obstetric care is all over the country based on a EMNOC facility survey done for Sri Lanka. So we have evidence-based practices for routine care and management of pregnancy complications. We have maternal care package and national guidelines on maternal care covering major elements. And the success is we have a competent, motivated human resources. Starting from the ground level, from public health midwife to the consultant obstetrician and gynecologist, we all are motivated. So that is the beauty of Sri Lanka. So they are competent, motivated. Fairly, we have an adequate number and geographically dispersed. So that is why, compared to other countries, we are doing well in stillbirth reduction, prevention, but with minimal cost. So when you look at the health expenditure in the world, total expenditure on health as a percentage of GDP, United States 17.1%, but our little country, we are ranked 172 with only 3.5%. So with that, we have achieved a better status compared to on par with the developed countries, and we need to do more. So these are the things which came to my mind. So still, I believe that we don't have a stillbirth prevention targeted approach launched from the ministry. So we need to focus approach for the stillbirth prevention. But overall, what we are doing ultimately summate to prevent stillbirth. And we need to have subnational targets and high-level monitoring, like for maternal deaths. So we need to go case by case. Ultimately, it's 1,800 number is large, and using ICD-PM classification is a very scientific classification system. Still, although it's little complex, we have problems in giving this knowledge at the hospital level. Sometimes it's done by MROs. So we need to designate a medical officer and train them. So we did it over the last 2 years, giving hands-on experience, exposure as well. But sometimes some trainees, they are lost to follow-up. So we can consider it as a clinical audit, and so basically, if we look at this to discuss among our peer doctors, and it's high time now that we using intrapartum stillbirth rate as a quality tool in our system, at least at hospital level. And we have now initial things done to have a population-based stillbirth register. The individual data, group level data are coming into our RHMI system. So we have developed a format because each and every pregnant woman is registered, documented, and followed up at field level. We can easily pick stillbirths from the community. So it would be another quality dimension we can add to our surveillance system. And we have had several discussions on how to review perinatal deaths at the central level. So we can start with a death review of selected cases. So in the coming years, next year probably, with the with the participation of all the stakeholders, especially College of Obstetricians and College of Pediatricians and other relevant parties, we can formulate or we can come up with a mechanism friendly in a friendly environment, de-identified cases, at least at national level, to do death reviews and come up with strategies to further prevent stillbirths in the country. And what I see is in majority of the hospitals, monthly perinatal death audits are, perinatal death review meetings are going on, but still whether we are using this data for action or practice change is doubtful. So we receive data and we have to press hard and hard to get these zero reporting, and ideally each health facility should send 12 monthly reports. Sometimes it's not so. And we need to again look at the perinatal death surveillance and response system. We have to have updated guidelines, and continuously we need to improve the capacity of all the people involved in this process. So it would be maybe not like maternal death, because the numbers are high. We need to have a good central level grip on each and every stillbirth. Then only we can see the true picture, the true ground situation, where we are. But basically we are, compared to other countries in the region, we are doing very well. So that is the overall picture of what we have done so far as a country, low and middle income country. But I must say, I have to appreciate all the contributors in the health sector, as well as our mothers and the general public in reducing stillbirths in our country. Thank you very much.
Thank you, Dr. Kapila, for your very informative presentation and also your efforts in strengthening the perinatal death surveillance system in Sri Lanka. So we are now moving to the final presentation of this symposium. The topic is interventions for ending preventable stillbirths. This will be done by Professor Atula Kaluarachi. He is the professor in Department of Obstetrics and Gynecology in the Faculty of Medicine, University of Colombo. He graduated from the University of Colombo in 1985. His research interests include infertility, advanced fertility treatments, and medical disorders in pregnancy. So he has done a lot of interventions to reduce maternal and to prevent maternal and the stillbirths. So I thank you for you taking this opportunity and also Over to you, Professor Atula Kalwarachi, to do the presentation on interventions for ending preventable stillbirths.
Good afternoon. At the outset, let me thank the President and the Council of the Perinatal Society for inviting me to do this presentation today. Looking at the interventions for ending the preventable stillbirths, my presentation will mainly focus on the clinical interventions that could be used to prevent stillbirths in the country. As already has been told, the WHO defines the stillbirths as births that are occurring after 20 weeks of gestation, which have no signs of life. Of course, there's a difference that is important for comparison in different parts of the world, so that you adopt one definition. Although, in certain other countries like US, they would define differently, saying it's after 20 weeks, and would define early, late, and term stillbirths. But for comparison, its WHO definition seems to be more useful. As you are aware, stillbirth seems to be affecting about 2.6 million families every year. And as already have been told, Sri Lanka's stillbirth rate remains around 6.5 per 1,000 births, not 100, per 1,000. And of course, there are so many reasons that have been shown to be associated with stillbirths, having different impacts on the risk of having a stillbirth depending on the condition. And I'm not going to deal with each and every condition, but just for the sake of knowing that there are so many reasons behind having a stillbirth, I have put this slide for you. And when you look at interventions, I would like to look at interventions which could be done before they get pregnant, the pre-pregnancy period, during the antenatal period, and during the intrapartum period. And of course, also look at how you can prevent recurrent stillbirths if you had a stillbirth in the first pregnancy. So we're looking at the modifiable risk factors which can be modified in the pre-pregnancy period. One of the things you could look at is, of course, having an ideal weight for before they get pregnant, because it has been shown that obesity is associated with high risk of stillbirths, and you have about 1.3-fold increased risk if you are obese. So it's important for you to have an ideal weight before you get pregnant. And also, there are data to show different things like smoking, alcohol, and various using of recreational drugs, which although this is not a real problem in our country, I've just put this slide for the sake of completeness so that we address all possible issues. Because the studies have shown that maternal smoking is associated with about 30 to 50 increased risk of stillbirths %. And it is also very important for us to make sure people who get pregnant are the people who should get pregnant and not otherwise. So that if you have already got a condition that increases the risk of stillbirth, it is important for us to intervene and provide them with effective contraception until they are suitable to get pregnant, or otherwise to avoid a pregnancy. So it's another intervention that you can look at is, of course, providing contraception for people who need contraception. It goes without saying, optimizing the medical conditions like diabetes, hypertension, or autoimmune disorders are very important, because if you allow the people to get pregnant with unhealthy situations like having uncontrolled diabetes or uncontrolled hypertension or otherwise, it is likely that they will end up with complications during pregnancy, even increasing the risk of fetal anomalies, so that ultimately all those will end up leading to a high risk of stillbirths. As we all know, the risk of stillbirths is increased in multiple pregnancies due to various factors. It might be discordant twins, it might be twin-to-twin transfusion. There are so many complications that can increase the risk of stillbirths. So, at present, the main factor that contributes to a higher risk of stillbirths, higher risk of multiple births, is assisted reproduction, so that we need to have some kind of mechanism to control the multiple pregnancies that are occurring as a result of assisted reproduction. As already told by Kapila, the folic acid supplementation seems to have an impact which you can easily implement to provide supplementation. And it's very important for us to look at people who had previous stillbirths, because it has been shown in most research work that if you have a stillbirth, you are at a higher risk of a recurrent stillbirth. So your interventions has to be planned much earlier than they get pregnant for the second time. Of course, when you look at what you can do antenatally, it will be very good if you can predict the likelihood of a stillbirth. But so far, there are different models that have been proposed. There are different tests that have been tried out using ultrasound scan, but none of these up to now is effective in predicting which baby is going to die. So those are not very useful. Looking at the chance of terminating the pregnancies, where babies have shown significant abnormalities, which can be sometimes lethal, which ultimately contribute to the stillbirths, as shown in the previous slide. Your majority of perinatal deaths were due to congenital anomalies. So you are just putting that number there simply because we do not terminate pregnancies with fetal anomalies. Certainly, if you can adopt that legal provision for terminating a pregnancy, of course, that will reduce the stillbirth rates. Anyway, that might not help the mother, that will help the mother simply to avoid carrying through a pregnancy without any advantage. As I told you earlier, it's very important to have a very good control of medical conditions, especially conditions like diabetes, hypertension, and autoimmune disease. They are important to be controlled before pregnancy, as well as they are very important to have adequate control and attention and during pregnancy, so that potential complications that would arise as poor control will not be there, and the risk to the fetus can be minimized. Implementing the national perinatal audits have been already spoken to about from the first lecture. The importance of it is because there is enough data to say that implementing such a perinatal audits are effective in controlling and reducing perinatal deaths as well as stillbirths. So it's something that we can look at, which is being started. I think that is something that we must embark on without delay. fetal growth restriction is another important thing that we have to look at during pregnancy. Because it had been very well shown that if you diagnose if you diagnose fetal growth restriction and if you manage them adequately, you can reduce the risk of stillbirths. In pregnancies where there is no fetal growth restriction, when your death rate is about 2.4, if the fetal growth restriction is detected and you intervene, your death rates can be about 9.7. But if you have missed and if you have lost the opportunity of detecting fetal growth restriction, your death rates are going to be almost 1 in 5. So it's about close to 20% when you don't detect fetal growth restriction. So it's very important during antenatal period whether you adopt the symphysis final handle measurement or using ultrasound scans. Fetal growth restriction detection and management is a very important intervention that you can do antenatally. If you look at the stillbirths that are occurring during pregnancy, the fetal growth restriction and placental abruptions seems to be contributing almost to 50%, taken together, almost contributes to about 50% of stillbirths that occurs during pregnancy. So it's looking at the risk factors for placental abruptions, paying attention to early warnings of placental abruption are very important when you want to intervene and reduce the risk of death of a fetus. Another important antenatal intervention that is available is, of course, the use of ultrasound scan. The ultrasound scan can be used in many different ways. For example, you can use the ultrasound scan to date the pregnancy so that you have an accurate dating of a pregnancy. You know, with that, your detection of fetal growth restriction becomes more accurate. With that, your risk of a postpartum pregnancy is less. You know when exactly the expected date of delivery, depending on the ultrasound dating. And it's very important to do it in the first trimester as well. And since we have patients booking very early in pregnancy, and that is an important strategy that we can adopt. Then the ultrasound scan, of course, can be used for your detection of fetal growth restriction. It is useful in assessing the risk of development of pregnancy-induced hypertension, as well as risk of late onset fetal growth restriction by looking at uterine artery Dopplers. Then subsequently, you can use the ultrasound to detect the fetuses at risk using growth as well as umbilical artery Doppler and the cerebral Dopplers. And also, it will be useful to use it for monitoring the fetal health in terms of looking at biophysical profiles. So the ultrasound scan also can be used in many different ways for your as an intervention to reduce the risk of stillbirths. The use of this fetal monitoring, it is not shown to be useful to use fetal monitoring routinely in all pregnancies to reduce the risk of a fetal death. But certainly, it is useful if you detect the fetuses at risk in terms of looking at fetal growth. in terms of looking at maternal complications like pregnancy-induced hypertension. Targeted fetal monitoring is useful, although routine monitoring in all pregnancies which are uncomplicated, there is no indication to say it's useful in practice. But certainly, in cases where there's a risk demonstrated, you can use it. Now, every mother, of course, feels fetal movements, and monitoring fetal movements, although in different countries, the programs are different, but whether that has an important impact in reducing stillbirths is, of course, questionable. Monitoring fetal movements, although it has been suggested as an identify fetuses who are at risk to prevent deaths, one of the largest trials that have been reported very recently has not shown its usefulness to decrease stillbirths. But again, as I told you, we need to first identify the pregnancies at risk by monitoring the fetal growth and looking at maternal and fetal complications, and target those fetal monitoring in terms of fetal movements, as well as the using of CTG and other biophysical profile and other means to reduce the risk of death of a fetus. Now, of course, this also had been looked at, whether you can reduce stillbirths by elective delivery at 39 weeks or beyond. Now, there's a very recently reported systematic review last year, which has shown that as the pregnancy advances beyond about 37, 38 weeks, risk to the fetus gradually increases. So that one of the easy way out, of course, to induce pregnancies at term, at 40 weeks or 39 or 40 weeks. And there are trials that have been going on that. But what we need to remember is the other side of, you have to balance between the risk of induction and having complications of induction, like increasing the cesarean section rates and other problems to the mother, against the risk chance of reducing stillbirth. So it's an intervention that has to be very carefully assessed and see whether it is worth implementing. Now, there are certain interventions that you could look at during intrapartum period. As I've been told by Dr. Kapil Jayaratne earlier, the interventions that have been shown to be effective and proven to be useful are having skilled birth attendants at birth, availability of basic and emergency obstetric care, availability of comprehensive emergency obstetric care, and of course, using improved monitoring facilities. Now, it has been shown if you can, rather than using normal cardiotochographs, if you can use computerized cardiotocography, which actually gives you interpretation of cardiotocography, graph pattern, is useful in reducing the stillbirths. So we need to look at how we can advance the intrapartum care and improve fetal monitoring during the intrapartum period to reduce stillbirths. Now, as I told you at the beginning, it's very important for you to look at, of course, if you have missed and if you have not had the opportunity of preventing a stillbirth in the first pregnancy, how do we prevent recurrent stillbirths? Sorry. So we need to. So there is no, once you have a stillbirth, there's nothing to say that what is the optimum period to have a subsequent pregnancy. You can look at different aspects in this case. Very important thing is, of course, before you decide when to get pregnant, for you to have a look at the cause of the previous stillbirth. So there's a very, don't look, it's a busy slide, don't worry about it. What it outlines here is the steps that you should take when you have a stillbirth, in terms of looking at the postmortems, in terms of looking at maternal health, maternal medical problems. Basically try to analyze what has happened and why the previous stillbirth occurred, because that will help to reduce a subsequent stillbirth. Sorry. Okay. Okay. And it's very important for us to realize that if you have a stillbirth in a pregnancy that is not related to a fetal anomaly, and if they happen to get pregnant subsequently, your chance of other complications, your risk of, as I told you at the beginning, the risk of stillbirth is also high, and also the other complications like having preterm birth and placenta abruptions and all that will increase in a subsequent pregnancy as well. So that your attention to manage a pregnancy where there is a stillbirth in the previous pregnancy has to be very, very important, and you need to have a very close antepartum as well as intrapartum monitoring in the pregnancy followed by the previous stillbirth. Now, when you look at managing a pregnancy where there's a previous stillbirth, you need to look at all these aspects. You have to look at the risk of a subsequent stillbirth and see what factors you can modify. You have to have a very clear management plan. You need to have a very clear antepartum monitoring pattern. You need to decide and determine the times of intervention for maternal and fetal benefit. And of course, it has been shown that if you have a more frequent monitoring and frequent visits and frequent assessments, you can have an impact on a subsequent fetal loss, although evidence is not that strong. Now, there are certain interventions medically that have been proposed to reduce the stillbirth subsequently. One is, of course, using low-dose aspirin. It has been shown that if you have a preeclampsia in a previous pregnancy and use of aspirin in a subsequent pregnancy is important to reduce the risk of preeclampsia in the second pregnancy. But in the absence of risk factors like preeclampsia, prophylactic low-dose aspirin is not recommended for subsequent pregnancies, and that has been the norm up to now. But there's very latest study that has been reported, trial, systematic randomized meta-analysis of randomized trials has shown that there's reduction of perinatal death with doses of aspirin over 100 milligrams. If you begin before 16 weeks, then there was a independent reduction of fetal losses in a subsequent pregnancy. So it's something that coming up new, and we need to explore these opportunities. Now, again, if you have supposing you have a stillbirth in the first pregnancy at, we say 32 weeks, then the usual recommendations are to start very careful monitoring at least 2 to 3 weeks prior to the period of gestation where the previous stillbirth occurred. So you need to have a very clear plan of fetal monitoring and also very clear plan of timing of delivery. Now, most of the time, if you have a stillbirth in a first pregnancy, you need to look at when to deliver in the next pregnancy. What is the available evidence says that in the absence of any particular complication in the second pregnancy, intervening before 39 weeks is really not recommended. But if you have risk factors for adverse pregnancy outcome, then timing of delivery must be individualized by balancing your maternal and fetal risk rather than adopting expectant management. So you need to be active if there are risk factors in a subsequent pregnancy to reduce the risk of stillbirth. So these are the interventions that are being proposed. And of course, for change the stillbirth trend, you need to look at not only the proposing and trying to come out with clinical interventions, you need to have of course, proper leadership. There needs to be a voice from women as well. We need to implement what preventive strategies that we can propose and measure the effect of interventions. And of course, as you said, we must audit and monitor the progress. And of course, we must look at our knowledge gaps so that we can reduce the subsequent risk of stillbirth. Thank you very much.
Thank you very much, sir, for your very interesting lecture. I would like to invite Professor Kaluarachi and Dr. Jayaratna over here. We are running behind the schedule actually, but still if you have few burning questions, we can take 1 or 2 questions.
So I must thank all 3 presenters. One joined virtually and the 2 speakers from who joined physically for your excellent presentation. I hope this opened our eyes on the stillbirth surveillance and also the stillbirth prevention program in Sri Lanka, so that we can achieve maybe successful results in the years to come, as it is one of the SDG agenda goals also that we are hoping to achieve very soon. So I must thank my co-chair, Dr. Sharma, also for enlightening us on this important topic. So thank you very much for the wonderful audience who are listening to the symposium. Thank you.
Thank you very much. Now I would like to invite our 2 chairpersons, Dr. Chitramali De Silva and Dr. Sharma Basnayaka, to hand over the token of appreciation to the key speakers of the symposium number 3, Dr. Kapila Jayaratna and Professor Atula Kaluarachi. Now, I would like to invite Dr. Kaushalya Kasturiarachi, President of the Perinatal Society of Sri Lanka, to hand over the token of appreciation to the 2 chairpersons today. Thank you very much. So here we move to the 4th symposium of the Annual Scientific Congress, themed Maternal Mental Health. To chair this symposium, I would like to invite Dr. Sanjeeva Gudakanda, Consultant Community Physician, Consultant in charge of Maternal Care Unit, Family Health Bureau, Ministry of Health, Sri Lanka, and Dr. Kapilani Vitanachi, Consultant Pediatrician, Neonatal Intensive Care Unit, Teaching Hospital, Karapitiya.
Okay, good afternoon everyone. Welcome to the 4th symposium of the session, and the theme is the maternal mental health, which is a very important theme and topic. And actually, in the past, this was kind of overlooked, but things are changing now. The Perinatal Society of Sri Lanka also has a lot of steps to address this area. And so under this heading, maternal mental health, we have 3 interesting topics by 3 eminent speakers. Of course, Dr. Seniviratna is joining us from UK virtually, but other 2 speakers are from from Sri Lanka. So I would invite those 2 speakers, Professor Priyanjali D'Souza and Professor Sunith Agampodi, to come on stage, please. I hope Dr. Priyanjali D'Souza is here and Dr. Agampodi, Professor Agampodi, please come on stage. Right. So the first topic is suicidal ideation in pregnancy. I hope our foreign speaker is online. Okay, she is Miss Trudy Seneviratne. I hope you can hear me. Trudy, we welcome you to the Annual Congress of Perinatal Society of Sri Lanka, and it's a pleasure to have you with us. Let me introduce you to this forum. Dr. Trudy Seneviratne, she is qualified as a medical practitioner in 1992 and later completed psychiatric training at South London and Maudsley NHS Foundation Trust, SLAM, and was a researcher with Professor Channi Kumar at the Institute of Psychiatry. She has been an adult and perinatal consultant psychiatrist for 20 years at SLAM. Dr. Seniviratne works as a perinatal psychiatrist and clinical director at SLAM. She has supported national development of perinatal services as well as being an active educator and disseminated numerous research over years. In 2019, she received an OBE for services to perinatal psychiatry and the President's Medal of the Royal College of Psychiatrists. She is a member and the Vice Chair of the National Clinical Reference Group Perinatal Mental Health Services, NHS England, Chair of the Perinatal Faculty, Royal College of Psychiatrists from 2016 to 2020, and elected as Registrar of the Royal College of Psychiatrists 2020. Over to you, Dr. Seniviratne.
That's wonderful. Just a quick note to say I'm absolutely delighted to be joining you from South London, where I am. So I'm not quite at the South London and Maudsley at the moment. I'm in my dining room. But I'm bringing you really good wishes all the way from South London, and absolutely fantastic presentations that I've just been listening to. So moving on to, if I share my screen then for the talk. I think that's with you now, isn't it? Yeah. Okay, to start with, so I'm going to talk about antenatal suicide, certainly, but also postnatal suicide. So as you say, this is an extraordinarily important topic, and I can't tell you the journey of why I became a perinatal psychiatrist now, other than to say that I didn't become a surgeon and became a psychiatrist because I thought that actually psychiatry was an area in medicine that I thought needed enormous investment, and that was having been to medical school in London, but having grown up and spent part of my life in Sri Lanka as well. And I have to say that perinatal psychiatry for me is, and maternal, antenatal, and postnatal suicidality, and completed suicide is just the absolute tip of the iceberg. And that's an enormous takeaway message that yes, we have completed suicide in pregnancy and postnatally, but it really is the tip of an iceberg when it comes to people who have violent thoughts of self-harm and taking their lives antenatally, postnatally. And actually, we now have 2 or 3 solid decades of research across the globe, including in Sri Lanka, some great research here as well, that tells us that the epidemiology of perinatal mental health is really quite devastating, and the rates of mental health are so high. So we have to really think about the whole person of the mother and the potential impact on the baby. So that's just a very quick introduction, because I could talk for hours about this. I won't. I'll try and condense it into about 20 minutes or so. So because of everything we know, actually there's an awful lot we can do. And I'm thrilled to see that there's a movement of introducing and rolling out maternal mental health programs in Sri Lanka. Absolutely thrilled to see that. So I remember when I started on this journey, there was only about 5 psychiatric mother and baby units in the UK in the mid-90s. Now, I know that sounds like a lot compared to the rest of the world. It is. And we now have 21 psychiatric inpatient units. However, we don't want people to come into hospital when they're so suicidal antenatally, postnatally, or have severe illnesses. You know, it's a bit of a luxury, isn't it? The reality is the majority of maternal mental health needs to be supported and looked after in the community. Really, the journey starts from preconception onwards, helping people to think about babies before they start to conceive. That's the ideal, thinking about personal histories of mental health, whether the delivery is a wanted pregnancy or not. And there's an awful lot we can do to prevent unplanned pregnancies, which then move into the journey of preventing completed suicides if we start that journey hard enough, early enough. And that's the other bit of any care pathway, that we start at preconception and in fact even before preconception, by getting into young women, for example, in their education at school, so that they don't have inappropriate pregnancies when they're young. So there's a lot we can do to detect, screen, prevent, and intervene. Globally, we've moved forwards, but there's an awful lot more we can do. So this is, you know, again, we talk about tips of icebergs, don't we? There's so much more we can do for this entire conversation to make a difference. So in the UK, for example, I remember my mentor, Chani Kumar, telling me to go and knock on government doors in 1998 and 99. It took another 15 years, I have to say, for the government to really grab the importance of this. So, you know, we're very lucky that we have standards for community services, inpatient services, even an organization like NSPCC, which is Society for Prevention of Cruelty to Children, hadn't looked at the focus on infant mental health, the impact on children. And the report on the bottom right here is that government wanted to know about the money and how much was this all costing, because that's what governments are interested in. And actually, this London School of Economics report on the bottom right-hand side, which came out back in 2014, told us that the cost of not intervening for mental health, particularly antenatal, maternal mental health and postnatal mental health, was a staggering 8.1 billion in the UK. And that wasn't counting the suffering, the untold suffering for women and families, or indeed the suffering from suicide. It was just through actual study findings that we had at the time. And most of that cost, sadly, was on the developing child. So 70% of that cost was on the developing baby. And that's another critical part of this conversation, that we have to understand that maternal mental health, if untreated, has an impact on the baby, not just the mother and the suffering, but the developing child and the family. And there are long-term consequences for the child if the depression or mental health isn't treated. We know, for example, that antenatal maternal mental health, anything that causes unnecessary or significant increases in stress, causes an abnormal stress response in the developing fetus. That can lead to a variety of factors, including premature labor. If we test, there are studies now, for example, the Vivek Glover's group testing the immunization response of newborn babies with their first set of IMS, and you see that babies born of stressed mothers, and it could be stress due to severe anxiety, depression, or indeed the stress that's created in a woman who's becoming suicidal in her thinking and not disclosing any of that to any of the healthcare professionals or her family. These babies have abnormal responses to the immunization, so they're hypervigilant in their responses, and that's an early indication, very early at 2 months post-delivery, that their HPA or stress response is different. And these children have now been tracked, and there's we don't want to blame the mothers for these changes in the fetuses and the young children, but the reality is the mother's mental health is critical in the child's development. So turning to suicide, in a bit more detail, one of the shocking factors, I think, I've been looking at the confidential inquiries into maternal deaths in the UK, which are triennial report. The UK has been doing this for many decades now. And I remember the report findings back in 2000, which actually shocked the UK Psychiatry, Obstetric, Maternity, Pediatric, Child Health World. It said that death from suicide, sorry, let me go back a second. Death from suicide was the leading cause of death for women in the pregnancy and postnatal period. So it wasn't death from physical health causes, it was death from suicide. Sadly, that statistic has not shifted in 20 years in the triennial report in the UK. So although conversations have moved forward, services have moved forwards, the statistic around antenatal, postnatal suicide has not shifted. So we still have an awful lot more work to do, certainly in the UK and right across the world. So if we look at suicide at a global level, we see, for example, 5 to 20% of maternal deaths in slightly more high-income countries due to suicide. The rate is moderately less at the moment, as we see in low and middle-income countries at 1 to 5%. So around 1 to 5 per 100,000 in high-income countries, and a pool prevalence in a meta-analysis of 1.68% in low and middle-income countries. So we see, for example, that in some parts of the world, there are higher rates in the Eastern Mediterranean, for example, the Americas, and lower areas, so Western Pacific and Africa, are slightly lower. Part of the challenge in looking at suicide antenatally or postnatally is that all places record it differently. And the World Health Organization helped us with this back in 2012 by giving us a classification system for maternal mortality, recommending that all suicides in pregnancy and up to 12 months postpartum were recorded as direct deaths rather than indirect deaths. That also made a real difference to how the gravity with which we placed suicide as an important factor in terms of maternal deaths. In the UK and elsewhere, we've also looked at infant mortality, but particularly infant and child homicide. And if we focused on the infant, very sadly, we see that in some cases where there is maternal mental health issues and maternal suicide, there can also be infant homicide, which is, an awful, shocking and horrible thing to think about. But yes, it does happen. And the toxic trio that we see in the dissection of these cases is the existence of parental mental health. So it's not necessarily just maternal mental health, it's fathers as well, substance misuse and domestic violence. But nevertheless, we see that children under 1 are the most likely to be victims of homicide of all children. So, it's factoring other extreme events happening to infants as well. So in thinking about suicide, we have to understand the literature. We have to understand, actually, we now have really plenty of epidemiological data to do something differently for preventing and reducing suicide rates. We knew years ago, this is Robert Kendall's work in the late 80s in Scotland, that psychosis or serious mental illness can increase immediately after childbirth. So there was a 22% increase in admissions for acute psychosis immediately after childbirth. And this is a statistic that's not gone away. Despite changes in mental health, we still have new onset postpartum psychosis. We still have women with serious mental health conditions such as bipolar affective disorder or schizoaffective disorder, where there's a known risk of relapse. And with that can come suicide, usually in the postnatal period, but certainly relapses can result in antenatal suicide as well. We've also moved in terms of the domestic violence knowledge that we have. So we know that there's significant amounts of domestic violence in women who experience suicide, ranging from physical abuse, psychological and sexual abuse, which is often not disclosed. We know that much of this can start in pregnancy. And we also know that intimate partner violence, and there's been plenty of research in that. Colleagues such as Pravichandra in Bangalore has done really great work looking at the importance of this. And again, stigma, it's not talked about, but certainly contributes to maternal mental health morbidity and subsequent suicidal ideation and possible suicide. The latest UK confidential inquiries also showed us that women are murdered from partners or ex-partners. That's just another spectrum of what can happen. So the epidemiology is very clear. In the more high-income countries, a conservative figure of all the types of maternal mental health problems, including suicide, is around 20%. That's a very conservative figure, probably much higher. And we see that the pooled studies across low and middle-income countries is slightly higher rates of things like depression, anxiety, post-traumatic stress disorder, obsessive compulsive disorder, and less commonly the psychotic illnesses. So, pooled, we're looking at least 1 in quarter of women struggling with their mental health and then possibly suicide. So this is a recent study in South London with my colleague Louise Howard and others, which showed actually in South London, because of the demographics and the socio-economic climate, the rates of common mental disorder were even higher at 45.1% for the under 25-year-olds and around 15.8% for the over 25. So the younger group particularly, the rates of illness are significantly higher, and we're seeing more cases of self-harming behaviours and thoughts, although we haven't seen the completed suicide data being significantly higher, although they are higher in the younger group. So what else do these triennial confidential inquiry reports tell us? They tell us that we have wonderful colleagues like this, Daksha Empson, who was a psychiatrist who very sadly had a bipolar illness and didn't have the right level of care. She developed a postpartum psychosis, and then she very sadly in that context set herself on fire, and her little baby Freya, both died. The painting on the top right represents many other women that have been cared for and that I have looked after, who sadly have taken their lives in pregnancy, mainly actually older, educated women who've taken their lives in the 3rd trimester of pregnancy. So this was the inquiry data back in 2000 that showed us that death from psychiatric causes was the leading cause. Interestingly, when we look at the weighting antenatally, we had only 5 for that triennial report who died in pregnancy. The majority were post the 42 days, were later in the postnatal period. And that's a pattern we've seen right through the 20 years, that the majority of suicides perinatally are in the postnatal period and less antenatally, which is an interesting difference in the data you have in Sri Lanka. So the next tranche of data, again, 1/4 of women dying by suicide. And we've now introduced learning from the case reviews and questions that professionals can ask around what we call, red flag symptoms and warnings. These include, for example, asking questions like, do you have new feelings and thoughts which you've never had before, which make you feel disturbed or anxious? Are you experiencing thoughts of suicide or harming yourself in violent ways? So we know that violent methods are very common, but women just simply won't tell you about them. So we have to ask about this. Are you feeling incompetent, as though you can't cope, or estranged from your baby, meaning are you feeling disconnected from your fetus, your growing baby? Do you feel you love your baby, want your baby? Are you looking forward to having a baby? So all those subtle questions that can be asked in a in a culturally specific context are really important, and not things people will disclose to you. And do you feel that things are getting worse? So one of the big programs in the UK has been the education of professionals. Again, this has been a 20-year program, but I think since 2016 we've done a lot more to look at professionals across universal services, so maternity, general practice, midwifery, but also secondary care across child health, obstetrics, as well as mental health services. So the latest dissection of reports, which we're still looking at the subsequent to this data, but the previous data was up to 2017. So again, 28% of women still dying through suicide. And that particular Trina report also talked about women abusing drugs and alcohol, and that was leading to the suicide as well. So cardiac causes have now just trumped maternal suicide as a leading cause in the last triennial report. However, and suicide is the second most common direct cause. However, if we look at the entire timeline from pregnancy right up to the end of one year, so when the baby hits 12 months, suicide is still the leading cause of death. And actually we see a weighting of suicides, meaning more suicides in the latter part of the first postnatal year. And less still in the antenatal period. Some other demographics, we're seeing that it's the white Caucasian women that are much more likely to take their lives in this UK sample, although there are increasing numbers, particularly of Asian women that we're seeing. It used to be the most likely demographic was a high educated Caucasian woman who was a primate, so it was her first baby, but actually it's across all socio-demographic groups as we've moved forwards. Often domestic abuse commonly seen, most receiving antenatal care and known to services. And in the timings of suicides, as I said, we used to say and still say, and I hear it being told many times, that pregnancy is protective, that women don't take their lives in pregnancy. This is simply not the case, and it's a part of our language we need to get rid of, to understand that women do take their lives in pregnancy, and often it's extremely violent. And those are just some of the methods that we've seen in the UK sample. We see, for example, in the Sri Lanka data that, and the data from India, that pesticide poisoning and poisoning is a more common method. Some of the other findings in the dissection, and actually this is why dissections of suicides are so important, because it tells us some of the etiological factors. So we see when we can get access to case notes that there is often a depression that has been recurrent and has been untreated. Some may never have had a history of mental health problems that's recorded, and that's also really important. So these are not women necessarily known to psychiatric services, and a minority are due to the psychotic illnesses. The vast majority are due to depression. There are also cases of women who have been known to mental health services or have been taking psychiatric drugs, who stop them because of fear of the impact on the baby, and then they go on to relapse and then take their life. So the importance of remaining on medication if that's needed, and also the use of injected all other drugs as a way of suicide. So this was an example of using propranolol, for example, that was given for anxiety management. And so plenty of learning over time to make a difference. We've got the red flag questions that we've introduced pretty much across the board in antenatal care and postnatal care. The importance of including the family, the partner and the family in conversations, the importance of communicating between professionals, but also the importance of the grade of assessor and healthcare professionals really being sensitive and asking these questions around mental health. Still a long way to go, despite an awful lot of training and support for people. And also learning that extended suicide, which is mother taking her life plus that of a baby, is an extremely rare event. it's much more likely that women want to take their own lives. This was another set of NKISH data, which is National Confidential Inquiry into Suicide and Homicide by my colleague Hind Khalife, which looked at all female suicides between 97 and 12, as well as perinatal suicide. And we see, again, that the weighting in the UK findings is more postnatal suicides than antenatal, but similar themes of recent onset of depression, less likely to be receiving treatment, younger, married, violent methods, and not using alcohol as much. So I was delighted that I met Dr. Kapila Jayaratne a couple of years ago, and we were in Bangalore in the Marseille Society meeting, and I got to hear about the psychological autopsy tool that is here in Sri Lanka for maternal suicide, or the PAMS. It's an absolutely brilliant. I really commend everybody who's worked on getting this forward. And it's probably the best dissection tool I've seen across the world, actually. So I think we should be taking this elsewhere. So in the UK, although we have high-level serious inquiries, immediately afterwards, the pool data at a national level isn't as rich as this immediate visit by a psychiatrist and a field healthcare worker and an immediate examination of what's happening. So in 2018, for example, there were 38 deaths in Sri Lanka, a rate of 11.7 per 100,000. So slightly on the higher side of the previous rates I showed you. So a real reason to focus on this. The antenatal period here is much greater for suicide than the postnatal period, which had a third. And primates again in the second trimester, and seeing poisoning as a more common method. And the majority were under 30 or adolescents, and with impulsive acts from complex social situations, interpersonal conflicts and lack of social support. A third with underlying mental health problems. So, similar themes, but we can do, the importance of looking at the local picture in trying to do a care pathway to change things. So in terms of what's happened in the UK, we've had an entire programme really trying to focus on this. As I said, this has been sort of a 20 or 30 year way of shifting things. So this is not something, this is into the long grass, takes years and years to shift, but I hope that the tipping point can get faster. The focus has to be from antenatal screening and detection from conception antenatally, with maternity services and primary care level. Having a mother and baby unit is an absolute luxury, but only a very tiny number will be admitted to such a service. What we have had is a huge rollout of community perinatal mental health services in the UK, particularly in England, which is fantastic because they can work alongside the maternity services and the obstetric services and really picking up and providing services. There's no point screening if you can't provide a service to support women, and supporting all women despite the diversity of background that they come from. So some of you will have heard of something called the Hooley questions, developed by Mary Hooley back in 1993. So these are routine parts of what we ask midwives to do, not just at the start of pregnancy, but right through pregnancy, and in the postnatal period we use them as a gentle way of opening up a conversation about mental health. So questions being, during the past month, have you ever been bothered by feeling down, depressed or hopeless? During the past month, have you often been bothered by having little interest or pleasure in doing things? So those are very sensitive questions that can, regardless of cultural language ability, can tease out existence of mental health problems antenatally and postnatally. There's of course the Edinburgh Postnatal Depression Scale, which you'll all be familiar with, developed by John Cox, which is also a good tool. We then need services, and I can't emphasize the important element is having listening professionals who are gently inquiring about mental health antenatally to tease out violent thoughts or suicidal thoughts that women may be experiencing antenatally, but then also to pick up any level of mental health problems. And then we have to be able to treat and support women. There's no point just leaving women hanging, having asked these questions. You have to offer psychological support in the correct setting. It may be non-psychological support. There may be a need for medication, but actually often women want non-psychological support and other ways of dealing with their stress. And then the big one is busting stigma. Actually, it's taken a long time to get to where we are. We still have a huge amount to do in terms of parity of esteem around recognizing the importance of the woman's maternal mental health, as well as her physical health and that of the baby, and helping families and the social network to really understand. And there's something we can do around planned pregnancies. So this was a study looking at the Hooley questions and EPDS, and actually the Hooley did really well in terms of positive prediction, as did the EPDS, but right across all diagnoses, it did pretty well. So we can, you can either stick to both or one or the other. And this is the story in Britain, where we've shifted from pretty much being red for having any perinatal services across the UK. With the injection in 2016, we're starting to turn the map green, particularly in England. We are not, although people would like to think we're green in England, we are absolutely not. There's an awful lot more to do. We're sort of getting there. And here are the 21 units we have in the UK. Another a really important way of getting to women and teasing out suicidal thinking and preventing and educating around mental health, if people don't want to come forward, is our digital technology. And this is just an example of something called the Baby Buddy app that we developed with a charity called Best Beginnings. And there's a colleague called Milushka Pereira who's actually working with the Baby Buddy group. This app, I think, is any app. I know there's one in Sri Lanka as well, which I'll show in a second. But this has been really good in getting to people, particularly young women, in helping them to understand not just their pregnancy journey. So you can create a little avatar for yourself and the baby right at the start of pregnancy and track what's happening. There's also a very gentle suite of video clips and sound bites that the mum can look at around her mental health, and the partner or the family can look at. And very gently, that's introducing a gentle conversation in thinking about mental health at a very early stage. And that hopefully will then continue into the postnatal period. So what can we do moving forward? So, we've come a long way. We've got an awful lot more to do. I think in Sri Lanka, there's some brilliant steps that are happening with the Perinatal Society of Sri Lanka, but also with the Royal College of the College of Psychiatrists there. I think please keep going, moving forwards and having a countrywide maternal mental health program, continuing to roll out antenatal and postnatal screening and services, really important, targeting the young mums. And actually older mothers are another at-risk group. Here we are using digital technology. I think that's an absolute way of getting to people. If we can't perhaps talk to people, most people do have a mobile phone now. There is digital exclusion with factors such as literacy, and depending on where people live, money, not having phones. But actually, digital support is a very, very good way of getting to people. And thinking family, the importance of including the entire family in this story, and the enormous part that stigma plays, and how much busting of stigma we still have to do within the society to make a difference. And I was delighted also to see the Forget Me Not app that's being developed in Sri Lanka for maternal mental health. So just very lastly, thank you so much for inviting me to speak at this very special conference. Special thanks to the Perinatal Society of Sri Lanka for inviting me, to Dr. Kaushalya Kathurarachi for the invitation, and to Dr. Kapila Jayaratne, who I've had the pleasure of meeting, who I know with his colleagues is leading some really important work in this area. Thank you very much.
Thank you, Dr. Senivaratne. Thanks a lot for that very informative lecture and enlightening us on this very sensitive issue. And on behalf of the Perinatal Society of Sri Lanka, I really appreciate, and I thank you for making, giving your contribution to make this event a success. Thank you. Are there any questions from the audience too? There's a question from Suranta.
Hi. Can you hear me today?
Yes,
Hello.
I can. Thank you. Yes.
Yeah, I'm
yes.
Suranta. I think we have
Nice to
communicated.
see you.
I have communicated with you. My question is, Sri Lanka already 1 or 2 places we have started bereavement program. We are training on that theme, and we think that is a need when it comes to perinatal issues. Relevant to that, 2 questions. Do you have a program at Kiel where we can send some of the people to get trained? And what type of a help you can extend to Sri Lankan program? Thank you.
Sarantha, I missed the first bit of your question actually. Did you say a program for suicide or maternal mental health?
Yeah. No, this is bereavement.
Around bereavement from suicide?
Yeah, no, bereavement due to
bereavement
neonatal
program, yes.
death, yeah, and the maternal death.
Yes, so there isn't a national program that exists for bereavement from suicide as such. So there isn't anything nationally. However, we do have a number of programs that happen at a local level, both at trust level, but also a number of charities, for example, Action Postpartum Psychosis offer something. We also offer a training from the Royal College of Psychiatrists. So, but we can say there isn't a national bereavement program particularly for perinatal suicide, if that was your question. So it happens very much at a local level. But you know, we're very happy to. I think that's a brilliant suggestion, and that we should probably think about something. I'm very happy to, to offer support in helping.
Yes, Trudy, we want to have a program address that theme at perinatal level, and we want to roll it out at national level. So we hope to get your help in future. Thank you.
I'd be delighted to help. Thank you so much.
Thank you, Dr. Senivaratne. So we'll move on to the next lecture.
Yeah, next lecture will be delivered by Professor Priyanjali D'Souza. Her topic is acquiring skills for being humane to mothers. As all of us understand, it's a highly relevant topic for this country. Talking about Professor Priyanjali, she is a professor in clinical psychology in the Department of Psychiatry, Faculty of Medicine, University of Colombo. She obtained her bachelor's and master's qualifications from the University of Delhi, India, and her PhD from the University of Colombo. Her research interests include mindfulness-based psychotherapy, child abuse, child-directed violence, postgraduate training in clinical psychology, licensure in clinical psychology, and cross-cultural aspects of psychology. Over to you, Professor Priyanjali.
Okay. So I know that we are like really well behind time, and I will try to kind of save some time for everybody. So I'm going to talk to you about something that I think all of us don't talk much about, because many times we talk about clinical skills and skill training, whilst we don't really talk about more deep human psychological development that should be the foundation of any profession, particularly in the health professions, including medicine. And that is about being humane. We know that the great distinction between humans and animals, other animal species, is humaneness. Which, of course, we do now see that sometimes animals are more humane than humans. We have seen that. But because we have highly more developed cognitive capacities, humans have greater tendency to connect with other humans with certain human qualities like empathy, kindness, compassion, which is so essential for the helping professions. So I'm going to talk to you about being humane, why it is essential, why it seems to be lacking in health professions, and finally the strategy by which we could be human if you are interested in being that. So the key word is if you are interested, because some people are not interested. Some people don't have insight of its necessity. So let's see what humanness is. It's like an inner flourishing. Now, when we are younger, I remember when I was in my 20s and 30s, we are much more focused on acquiring certificates, degrees, and skills. It's more like those external things of a tree, like the flowers and the fruit. And many times we are interested in the flowers and the fruits of a tree, but we don't really look at the bark, the strength of the bark, the strength of the root system, which actually sustain these fruits and flowers of a tree. So when we talk about humanness, we are actually talking about the trunk and the bark of a tree and its strength and its root system of a tree. So humanness is actually inner flourishing of a human being, which we don't see much in our society. Of course, the well-known examples of humanness would be somebody like Mahatma Gandhi or Nelson Mandela. Or there are so many little-known heroes that are not as famous as the ones I mentioned, but who may be in our villages, in our own hospitals, in our base hospitals, who we see as epitomes of humanness. So this human flourishing of a person could sometimes be unveiled. You know, you just go on as you live from year to year in your life, you see that you have changed into somebody very special, and where other people consider you as somebody very special because of your personality qualities. Sometimes it is willed. I remember when I was in my 20s and when I had come back to Sri Lanka after my studies in psychology and I joined the Faculty of Medicine, I was the youngest lecturer not only at the medical faculty but at the University of Colombo for a long time. And I remember my schoolmates who were in my batch in school were final year medical students, so they were my students, and I didn't realize how egoistical I became because of the positionings that I got just simply because I existed in a particular time at the University of Colombo. And then one day, a particular incident happened to me where I was at Ward 59, our psychiatry ward. I had seen a couple of patients, and I had to go to Kinsey Road to give a lecture. I was about 25 or 26 years of age. I was a lecturer at that time. And there was only one entrance to in and out of NHSL. And I took my vehicle out, and there was this white color kind of van blocking the main entrance. And I felt this rush of kind of annoyance that came into me, where I thought that how could this, in my mind, how could these very fools park this van where people, important people like me, have to go up and down? I'm being very open to you about my mental state at that time. So I got out of the vehicle, my own vehicle, and I went to the van, and there was no driver. So I looked inside the van, and there was this man on a reclining, the back seat of the van. He was lying on that, like lying down, and there's a child on his chest who was sleeping. So I asked in my most arrogant way, co-driver. And then he told me, Madam, driver kiyanne mage yaluwek. එයා ගියා OPD එකට ලොකු මහත්තයා ඇවිල්ලාද කියලා බලන්න. මොකද මැඩම් මට ඇවිදින්න බෑ. So he had a spinal cord injury, and he said මේ මගේ දරුවා මගේ නෝන මාව දාලා ගිහිල්ලා. And at that moment I realized that all the psychology I knew, I practiced on patients who themselves got well, where I set examination papers, had no impact on my own mind. So when we talk about humanness, we talk about these very special qualities that we do not treat people in a certain way. We treat people in a human way. So I've given this example of my own life for you to appreciate that you will also have these same stories in your own life which you have not considered as important to be human. So when we say, and at that particular instance, I realized that before I could help anybody else to be human and psychologically healthy, I need to be that. And that's why my own will journey of humanness started. So when we talk about humanness, how do we know if we are human? For example, do you look into the needs of others who don't directly benefit you? Such as the security guard in the hospital that you work with. Do you acknowledge him? Or is he so unimportant because he has no direct relevance to you? Or the person who opens the door for you when you came into Watersedge? Or the person who is serving food for you at the buffet table, do you consider him as somebody important? Do you look at his eyes and acknowledge him? Because they like acknowledgement. Many people just go straight above their heads because they're not of relevance to you. How do you treat the nursing officers or the attendants who work in the ward with you? Do you know their names? Do you know about their life? Or are they of no relevance to you? If they're of relevance to you, if you have that attitude, you are human. Another quality would be, are you the same to the janitor and the president? Or would you ingratiate when the president comes to your ward, but the janitor, you don't care whether he falls dead because you can get another one? Do you have that attitude of mind? Are you plagued with sense of ego, like the example I gave you about myself when I was 25, 26 years of age, where I felt that I was quite an important person. I'm sure I'm the only one who thought that way, but I thought that way. Are you full of ego and self-importance, which is quite distressful and disgusting for others, but you don't realize that? Are you competitive as opposed to cooperative? We know as we work in teams, in wards together, we see some people who always look off the backs of another person, and there are others who are competitive even if you get a scholarship to go to India for a conference. They just get plagued by jealousy. So these are kind of qualities that one would develop as you become more and more human. You become like the best version of a human being. It is usually shown by a sense of warmth a person radiates towards another person. So usually when you are in the company of a human person, you could feel that person is human. You could feel that person is, people get drawn to that person because of certain internal qualities the person has. That person's clarity of mind is very well seen, the way that person talks. It's not because of an intellectual growth. We know there are people who have, sometimes you see people who have 2 PhDs, and I wonder why would you want to do 2 PhDs? It's like 8 years of study, and why would you want to do that? So they're not talking about that kind of intellectual growth where you collect degrees, but where the clarity of mind comes because of the development of certain personality qualities. And most importantly, a humane person is very present with the moment they find themselves in. They are not restless. So this is what humaneness is all about, and you might realize that in the health profession, particularly in medicine, these human qualities are so important. We do know that many medical curricula across the country have included training in humaneness. The Faculty of Medicine at the University of Colombo has been teaching humanness for over 20 years. Some students take to it well, others reluctantly, others not at all. And one of the things that our students say is that, yes, theoretically we learn them, but when we go across to various hospitals, do our clinical training, we may not see it embodied as role models in those who work in hospitals, and that's a problem. Because the students need to see people who are actually in the situation working with humaneness. And that comes to, how do we become human? So, of course, to become human, you need to value it. You need to realize that above anything that we achieve in life, the most important thing is to be human. As I realized when I was in about 26 years of age with that incident that happened at the National Hospital gate, I realized whatever I have, if I don't have these qualities, life would be a little mediocre for me all the time. So the key way to develop humanness is referred to as mindfulness. We also call it present moment awareness. In Sinhalese, we call it sihiya, sihiyen jeevat veema. So what is mindfulness and what is mindfulness not? So if I ask you, there are some of you who are eating, some of you who are eating and listening, some of you who are eating, listening, and talking, and there are some of you who are eating, listening, talking, and checking the mobile phone. Is that okay? And some of you who are sleeping and eating. So now when we say living in the present moment, A person who is living in the present moment is characterized by knowing exactly what his or her body is doing and what goes through his or her mind. Now, as you sit here, are you aware of that? Are you aware of exactly what you're eating? Or are you just shoveling things into your mouth, not knowing what it is? Are you absent-minded listening to my talk while checking your next WhatsApp message? Or you're aware of my voice, but your concentration is very well established in that WhatsApp message. That's the difference. So, when we say let's live in the present moment as the key strategy to be human, what it involves is keeping your mind on the activity what you're doing. So a person who is practicing living in the present moment would, for example, when they get up in the morning, would be aware they are up. Some people are not. They're sitting there sleeping, but they're up. So they're aware, I have woken up, I feel groggy, I feel a bit sad, but I'm up. And then when they walk to the washroom, they are aware of the walking activity. Many people are not even aware, they think they're sleepwalking, but they're actually awake, going to the washroom. And when they do take their toothpaste and their toothbrush, they're aware of the activity of putting the toothpaste onto the toothbrush. Many of you, if I ask you now, did you brush your teeth in the morning? Would you remember if you do? You might think you have, but are you quite sure? A person who is practicing living in the present moment would know what they do. Many of us don't value this necessity. We think, well, brushing the teeth, I do it all the time. Eating the food, I do it all the time. Walk into my car from the ward, I do it all the time. Let me use that time to do other things in the mind. Because, who would want to know how to brush the teeth? I remember now a lovely story. I saw an interview that Shah Rukh Khan, the famed Indian actor, had with Sumi Agarwal. She was a very well-known Indian interviewer. And at that time, Shah Rukh Khan was becoming #1 in Bollywood. This is the 90s. So Sumi Agarwal asks Shah Rukh Khan, how is it that being of an ethnic minority in a predominantly Hindu country, coming from a refugee camp, from a very poor family, without any connections in Bollywood, he became #1 actor. In fact, Shah Rukh Khan is the highest paying actor in the world, even more than Tom Cruise in Hollywood. And Shah Rukh Khan says, I came from a refugee family. I lived in a refugee camp in Delhi. My parents were very poor, and I decided I don't want to be poor. And my father told me, Shah Rukh, whatever activity you do it well. You do it with awareness. And he said, even when I brush my teeth, I do it with awareness, and that's how I became #1. So when we say present moment awareness, how you train the mind to be that is where whatever activity that you do, you keep your minds on that. For example, if I was to give you a simile of a book rack, you will have a bookcase and it will have racks. And you would keep the books on the racks. Like that, you would keep your mind, which is like the books, on the rack of the activities you're doing. So if it is putting toothpaste on your toothbrush, you will be aware of what you're doing. And when you're aware, you will see your mind is running to other things, like the breakfast you have to make, or the patients you need to see in a busy clinic that morning, or your child's online homework activity, or the fact that you're feeling a bit feverish. If you're practicing present moment awareness, what you would now do is know that your mind had wandered to another place other than your toothpaste and toothbrush, and gently bring it back to the activity at hand. So if your mind wandered 7,222 times in the day to outside activities rather than what you should be at, you will bring it back 7,222 times. As you keep on gradually training your mind to bring your mind back from wherever it has wandered, what happens is that something strange happens to your personality. Your mind becomes very strengthened because you don't get involved in other things that are actually extraneous to what is happening now. You're not involved in all these external thought processes. and your mind becomes very strengthened. Your mind becomes concentrated, it becomes very calm, and it becomes very still. And in that stillness of the mind, these great human qualities of kindness, compassion, tolerance, proper judgments, proper decision making starts flourishing. We know that many times, many of us do not live in the present moment. Rather, we live in 3 other places. One is the past. I have an aunt of mine who's in her 80s. She still talks about her grandmother who scolded her when she was 15 years at some dani. Now the grandmother has died, has been buried, there must be trees growing on her, and this one is also about to kick the bucket, but still talks about that grandmother. And in a very perverse way. Unhappy, but in a perverse way, likes talking about it. How many times do we dwell in the past rather than in the present? Another aspect that we live in is the future. Planning for the wedding that might happen in February. You can plan, but you don't need to dwell on it. The third place that most people dwell in is fantasy. Thinking about the Nobel Prize that you will never win, but you can still fantasize about it. How you go to Oslo and get it, and how you smile, and you will be the center stage in Sri Lanka for the next 20 years. But it won't happen to you, but you can fantasize about it. What we see is every time the mind goes, either voluntarily or involuntarily, to these 3 places, past, future, and fantasy, initially you get like a kick. But afterwards, your mind will become restless, depressed, and disappointed. There's a dump. The reason is your mind knows these are false places. The only true place is here and now. So therefore, when you keep practicing being in the present moment, what do you actually do? You keep your attention to the current experience. So for example, if you are listening to my talk, your most immediate current experience is the talk we are doing. It could be your food as well as the main current experience. Whatever it is, keep your mind on that activity. Secondly, be aware of it without processing extra thoughts about it. Now sometimes we might sit here and you might see me for the first time, and then it might trigger, oh, doesn't Pianjali look like my Montessori friend Anusha? Oh, I wonder how Anusha is. I wonder if Anusha is married. Actually, do you think Anusha is on Facebook? Now you take your phone and you're on Facebook finding this Anusha, while the talk is on by Pianjali on humaneness. That's exactly how the mind wanders. But a person who is training the mind to be in the present moment would catch the thought that yes, Pianjali does look like Anusha, but would stop there. There is no elaborate proliferation of thoughts, but instead bring the thought back to what I'm speaking about. When that happens, over time, with gradual training, it won't happen in few weeks, it will not happen in many months, but over time you will see that your ability to tolerate negative thoughts of anger, jealousy, sadness becomes very powerful. So for example, if I'm a practitioner of present moment awareness, I may be going through the most distressing life situation in my life. I'm not, but if I might be, I could still come here, talk to you about humanness, talk to everybody here in a very kind way, and still go from here bearing the distress I'm feeling, and you wouldn't know about it. I have not become a problem to you. I have not become a problem to myself. While so many of us in our own lives, when we are having a distress, somebody else also suffers because of it. At least it could be your dog because you kicked him, or your child because you slapped her, or the attendant in your ward because you took it out on him or her. That's how we always give it out to others. A person who is trained in the mind in the present moment and therefore to be human can tolerate those negative emotions and keep it within herself. And because of that, they become disengaged from unhealthy habits and behaviors. So their tendency to get involved in substance misuse, excessive shopping, destructive self-harm behaviors, all starts reducing over the years. They accept a present situation, however challenging it might be. May it be the diagnosis of a difficult illness, a life-threatening illness your child is going through, a promotion that you should have got but you did not get, a huge financial difficulty or the present day COVID situation, whatever it is, they are able to accept it rather than fight against it, but still do certain things that is within their power to try to change it. So what happens therefore is with this mental set, the person becomes very powerful, and it is that power of calmness that we call humanness. And finally what happens is, I want to show you this slide. A teacher had asked the children in their class to draw the shortest way to the milk bowl. And the child said, well, it's outside. It is the shortest way, and it's the quickest way, and it's the easiest way. And the teacher gave the right and a red mark. Because you see, it is our thoughts that makes life difficult. It is not life itself usually. Because we overthink and elaborate beyond the present situation, we get all distressed. So living in the present moment, training our mind to be in the present moment, overcomes all sorts of excessive thoughts where you become living only with the required thoughts. And that is what strengthens the mind. And a strong mind is a human mind. Thank you very much.